Yep. So, hi everyone. Thank you so much for joining our seminar today with Dr. Daniel Robin on the topic of how to determine if one injury caused another injury. Just some house rules. During the presentation, the attendees will be muted to avoid any random noises that might distract the presenter. So, if you have any questions, please pop them in the chat box and we will attend to them. So today we have Dr. Daniel Robin, who is a Melbourne-trained consultant orthopedic surgeon who treats all elective and traumatic orthopedic conditions. He has developed a lower limb subspecialty interest, specifically in the treatment of sports-related and degenerative conditions of the hip and knee, as well as hip dysplasia and patellar stabilisation in the young and sporting adult population. Mr. Robin is also an advocate and proponent of the latest early mobilization and rapid recovery techniques in appropriate and motivated patients. So over to you, Dr. Robin.
Thank you very much, Sophia, and thank you to MAG for hosting this session. Yes, as Sophia says, I'm a orthopedic surgeon. By way of background, I'm a consultant surgeon of 16 years experience now as a consultant, plus something like 5 or 10 years before that of non-accredited or an accredited training in orthopedic surgery. So 25 odd years of orthopedic experience all up. I am trained in AMA and qualified in AMA for upper limb, lower limb, spine and scarring. And I'm fairly new to the medico-legal field. I've been doing this for just under 12 months now. So I'm still finding my way and learning the ropes a little bit. So the section on what an expert needs may be has my own personal bias to it, and the things that I've sort of noticed in the early days. And the section on how one injury may or may not have caused a later injury hopefully will be of some interest to you. So without much further ado, I will commence. Now, hopefully I will share my screen and hopefully that's working for you all. Okay. So, and by way of brief overview, I'm going to quickly talk about what a medical expert, or in particular an orthopedic expert, needs for an independent medical assessment or a joint medical assessment. And then we'll move on to the bigger topic, which is how, the controversy about how one injury may cause a later injury. And being a lower limb surgeon predominantly, and I think in clinical practice, this is certainly the case, that we get patients complaining of a alteration in their walking causing another problem somewhere else in their body. So we'll talk on that quite a bit. So what an orthopedic expert needs to do an IME. So part of the job as an IME is to establish a diagnosis. In other words, what is the single condition that is, or single group of conditions that might be causing a client to present. A diagnosis in its own right is actually a constellation of things. It's not just the patient's complaint, but it's their individual complaints of various symptoms like pain or swelling or stiffness, but it's also associated with physical findings that as a doctor we will be able to establish. So they've got tenderness in a certain location or restriction in movement in a certain plane. And then we use corroborating evidence as orthopedic surgeons to look at what pathology may be going on. And for us, that means things like scans. So X-rays, CAT scans, MRIs, to a lesser extent ultrasound, to a much lesser extent ultrasound, but X-ray, CT and MRI are the main things that we will look at as corroborating evidence. And the reason why I bring that up is it's quite important, certainly in orthopedics. When it comes to documentation, the things that we like to see as IMEs would be things like ambulance and emergency department reports. That helps us establish the probable mechanism of injury if it's been a significant injury. The radiologist reports are helpful, but they are not the be-all, end-all, and I'll bring that up in a minute when we talk about the imaging itself. Operation reports are really, really helpful because they give us a really good indication of not only what treatment has been required, but it also gives us an indication of how severe the injury really was, determined by what procedure was required to treat it. Discharge summaries from hospitals and or allied health professionals are often helpful because they summarise what's gone on in the time course during their treatment. And lastly, notes from the treating doctors or the GPs can be really helpful in some instances, not always, but usually, once you sort out the wheat from the chaff, because then we get an idea of either a summary of what's gone on, but also there are other past medical problems that can be important to consider. When it comes to actually the interview or seeing the client, being able to take a history and perform a physical examination has a number of purposes. Number one, it confirms the veracity of what we've distilled from the documentation, and it gives us an opportunity to amend any information that we have by confirming with the client what their injury was, how it's occurred. It gives us the opportunity, obviously, to assess their current symptoms. So, and in orthopedics, there's only literally about 7 symptoms that we actually have. Patients or clients either complain of pain, swelling, deformity, stiffness, instability in a joint, so the joint gives way, and then we've got neurological injuries like altered sensation or limb weakness. Beyond that, there aren't a lot of other symptoms that patients can actually complain of. Of course, there are variations within that theme, but that's about the guts of it. Then we can actually establish from the client or the patient what are the functional consequences of their symptoms. How do they conduct their activities of daily living? And so there are personal activities of daily living like being able to dress yourself, being able to wash yourself, being able to feed yourself. There are domestic activities of daily living where you have to look after your household. So things like doing the dishes, cooking meals, cleaning the house, doing the gardening. And then lastly, there are community-based activities of daily living. So getting out and about, going and paying your bills, getting to work, holding down a job. Those sorts of things are community activities of daily living. So we can make that assessment based on talking to the client and seeing what their limitations are. The last thing that we do is actually assess for signs of, physical signs of injury. So moving joints, moving limbs, looking at scarring and those sorts of things. And we can also make an assessment of what the extent of the pathology is by the physical examination, and also what the consequences of any treatment might have been since they've had treatment. So for instance, if they've had surgery, have they ended up having a very large and unsightly scar, or have they had arthroscopic or keyhole surgery where they've got very small scars that are barely noticeable? The last thing that an orthopedic expert needs is the imaging. And that's in orthopedic terms, I think that's actually really, really important. And there's a few reasons why that is. The radiologist reports are all well and good, but they don't see it from a surgeon's standpoint, and they don't always have the clinical context adequately explained, so that the description on a piece of paper doesn't necessarily paint the whole picture. So it's seeing that imaging myself as an independent medical examiner, but also as a treater, obviously, is really, really important. There are instances where radiologists, to the best of their ability, have unfortunately missed other injuries that have occurred, coincidentally or at the same point in time, but they've missed another injury, and that can have significant impacts from both a treater's point of view as a treating doctor, but also from the point of view of an independent medical examination, because then we get into the subject of what is the diagnosis, but are there other diagnoses that should also be entertained? And if there've been other injuries missed, well, if you don't see the imaging, you don't know about the other injuries. Lastly, as an IME, we get an idea of the extent of the injury. And again, we don't always get a great feel for that reading the radiologist's reports necessarily. But once you see it in pictographic form or in pictorial form, it makes a big difference. So here's an example here of a woman who had some missed injuries. So if I hope the image projects fairly well. The x-rays on the top left-hand side of your screen show a series of x-rays, 3 x-rays of a left ankle of a woman in her 60s. She fell down some stairs, she twisted her ankle joint, and she had 3 very, very readily detectable injuries that the radiologist accurately picked up. She had a fracture of the inner corner of her ankle, which is the circle on the left. I'll just see if I've got a pointer. Hang on. I'm not sure if that's a pointer or not. Anyway, so on the left-hand side, the inner corner of her ankle has a medial malleolar fracture. The left-hand side of the ankle, or the outer portion of her ankle down here, had a small piece of bone pulled off by the ligaments. That's called a fibular tip avulsion. It's an indication of significant ligamentous injury, more so than bony injury technically. And then lastly, there was an unusual injury down the bottom of her foot, which you see in the circle at the bottom here, where she had also had a chunk of bone yanked off by the tendons on the outside of her ankle joint. So those were 3 unusual injuries to come in combination. What's more interesting though is what happened once we did the CT scan of her ankle, and we got lots of extra information of injuries that the X-rays missed. In particular, if you look at the images down on the bottom of your screen, you'll see the red arrows. Now, the red arrows are pointing to all the other injuries that were not picked up on the original radiologist report, and yet were seen both on scrutiny of the X-ray and also on the CT scan. Specifically, she had a talar dome injury, a, a calcaneal fracture, and a navicular fracture that you can see here on the CT scans as well. So, and these have significant implications both as a treater and as an IME. So as a treater, it says to me, well, look, this is a much more serious injury. The treatment protocol is going to need to be different because we've got other injuries we need to consider. And that has implications on how we treat it, but also what the rehabilitation is going to be like, what the weight-bearing status is going to be like. When do they start physical therapy? When do they return to normal activities? When can they drive? These are all going to change depending on what these other injuries show us about what's happened to that lady's lower limb. As far as being an independent medical examiner, if I've picked up these other diagnoses, well, if we're looking at the lower limb, there's a section there in AMA4 that looks at diagnosis-based estimates. And if you're looking at the spine, diagnosis-related estimates. And if you're picking up additional injuries, these are often having implications for their whole person impairment, because these are all additive or cumulative to their whole person impairment. So having access to those images will often allow us to pick up additional problems that may have significant implications. So for me, getting access to those images can be, well, A, very difficult, but B, very important. So if you guys can facilitate that in any way, shape or form, if your clients have CDs of their images and the like, it's really important that they bring them with them so that those images can be accessed. Not all IMEs like to look at those things, but hopefully most orthopedic trained IMEs would. So I think that brings me to a conclusion on what an independent medical examiner needs, at least from an orthopedic surgeon's point of view. If there are any questions, maybe we can circle back to those towards the end of the talk. The next section, though, is related but not quite the same. So how can a client claim that having had one injury causes a later injury? And by that, we're thinking of things like for example, I've hurt my right knee. My right knee is in pain. I'm now limping because of my right knee. And the limping from my right knee injury has now caused me to put extra pressure on my left knee, my left hip, my low back. Well, funnily enough, if we want to distill this down into a sentence, this sort of thing is actually, it's a lot less likely to be causing an injury per se when you've got one joint that's disabled. It's a lot less likely to cause a true injury to other parts of the anatomy. And by that, what we're talking about is mechanical dysfunction or significant deformity in that other part of the anatomy, let's say the opposite hip joint for argument's sake. This sort of thing is actually not that common, and it's very hard to prove. Now, if you have a look at the cartoon on the bottom right-hand side, I've got a little section there talking about pain versus injury and pain versus diagnosis. So what I mean by this, and what I want to bring home to you guys as non-medical people, is that having pain by itself is not necessarily the same as having an injury, and having pain by itself is not the same as having a diagnosis as far as the American Medical Association guides are concerned. To have a diagnosis, really you need to understand what the actual abnormal process is. And just having pain doesn't necessarily mean there's a major anatomical problem. It may just mean muscle strain, it may mean ligamentous strain, neither of which get a diagnostic sort of value or a whole person impairment as far as the AMA guides are concerned. And so really, when we're talking about my right knee is now causing my left knee to hurt, well, that's not usually the case. As an orthopedic surgeon, we need to figure out what is the actual, pathoanatomy, what is the damaged structure? Is it bone, is it joint, is it ligament, muscle or tendon, and what's going on there, and whether or not that actually meets a diagnosis that fits in with the AMA guides. So that's an important one to take away. So now, in order to understand what happens in the lower limbs as far as one injury causing potential later injuries, unfortunately, you're going to have to learn a little bit of orthopedics. And I'm going to try and cram in 12 months worth of orthopedic understanding as a first-year trainee into approximately 5 or 10 minutes. So we're going to quickly talk about how we normally walk, or what is called gait, what happens when gait goes wrong, limping, and then the biomechanics of what happens when the gait is abnormal and how that may or may not have implications on other normal joints in the lower limb. Hopefully I don't bore you too much. Okay, so when we walk normally, we are effectively moving our body's center of gravity or our center of motion, which if you have a look on the cartoon on the bottom left is around the level of our umbilicus or belly button. And we're moving that center of gravity efficiently, continually, smoothly, and usually forward. When we're walking, if you have a look at the cartoon on the top left of screen, you'll see that when we're walking, we have our, let's say for argument's sake, if we're looking at this black limb in the cartoon, that limb is in contact with the floor about 60% of the time that we're walking. The remaining 40% of time, that black limb is going through what's called swing phase, where the limb is not actually in contact with the floor. And that's normal. That's normally how we walk. When that lower limb is in stance phase or in contact with the floor, that's when it has basically the majority of the body weight on top of it. And if you think back to any physics you might have done in high school, when we've got pressure of body weight pushing down on something, if that something isn't going to fall away from underneath us, that something has to push back at us. In this case, it's called resultant force or ground reaction force. So the ground is pushing back up on the foot that's pushing down on it. Now, when the body exerts force onto the lower limb, we actually aren't just exerting our body weight in a static sort of situation. We're usually having the force multiplied by things like speed and gravity with which the limb is moving. And so at the highest point or the most weight intensive or pressure intensive point in time during walking, usually when the heel hits the floor, the actual force going through the lower limb is something like 6 times our own body weight. So if you weigh 80 kilos for argument's sake, at the point where your heel hits the floor, if you're walking briskly, you can actually be exerting something like 480 odd kilos of pressure or force through that heel. So it's significantly more than just when we're standing still. When we're standing still, all we're doing is exerting our body weight on that lower limb. But when we're moving, it's a force multiplier. Now, when that limb is actually being swung through in our swing phase, 40% of the gait, the only thing that's really working on that limb at that stage is the pull of the muscles, which in comparison to our own body weight against the floor is actually fairly small. So again, thinking about physics, when we think about the concept of force or how much energy is being exerted, that is a multiplication of our mass, so in this case body weight, multiplied by the acceleration that we're putting the limb through. So how quickly we're moving that limb. Now, if we look at things like pressure, when we talk about pressure, what we're talking about is how much force is being applied over a certain area. So you can see that it's inversely proportional to the area that we're applying that force. So if I get a 10 kilo weight and I have it shaped like a square, then that 10 kilo weight over that square shaped area is going to exert a certain amount of pressure. If I take that same 10 kilo weight and I make it into a much, much, much smaller square, for argument's sake, turning it into a column, a tall column of metal instead, the area that's going to be exerting its force over is much smaller. And so the pressure at that surface is going to be much higher. That has significant implications when it comes to our joints, because when our joints are put in certain positions, we increase or decrease the area over that joint that's actually taking the pressure or taking the force. And you'll see how that comes into play in a minute. So when we have abnormalities of our gait, we then see an asymmetry in our forward motion. And that's most commonly seen by what's described as a lateral lurch or a lean off to the side, or alternatively, an asymmetry in the forward movement, like a stutter or a vertical movement rather than a smooth forward motion. Now, these inefficiencies that we see when gait is abnormal causes an increased energy when we have to walk, or it puts more stress on our cardiovascular system. Now, our body will try and adapt to this in various ways by making that abnormal walk more efficient in certain ways. And I'll show you some examples of that in a sec. So that leads me to the concept of limping. What is limping? Limping is our body trying to adapt to these abnormalities of gait. So there are 3 different types of limp. The first type of limp is what's called an antalgic limp or an antalgic gait, where our body is trying to avoid pain in a bone or in a joint. The second type is a limp that we get when our nerves, muscles, or tendons, the things that drive the joint, are damaged. And then the last type of limp we see is when there are significant deformities within the joint. Either the limb is much shorter on one side than the other, so the right leg's much shorter than the left, for argument's sake, or the angles in those joints are significantly different. So the knee has a significant bend in it, and therefore that shortens the limb essentially. So when we have an antalgic gait, intuitively we take less weight on that painful limb. The limb itself has normal muscle power, so the limb can be driven normally, but we want to try and spend less time on that sore limb, and so we hasten the swing through of the good limb, so the uninjured limb, to get us onto that good limb quickly, and we try and shorten the amount of time that we spend on the injured limb. This in turn leads to a prolonged period of time where we're spending more time in stance phase or weight bearing on the good limb. And of course, that results in an asymmetry in the forward progression of the center of mass. A little bit complicated, but it kind of makes sense when you think about it. Now, the one that's a little bit less intuitive is the paralytic limb. So in patients who've had things like a stroke or cerebral palsy, where the nervous system has been damaged, or in infectious conditions like polio, which probably most of us aren't old enough to have ever seen someone with polio because it was basically eradicated in Australia in the 1950s and 1960s. But polio was a viral infection which ate nerve endings, essentially, motor neurons. And so these cause paralyzed muscles. So when these muscles are paralyzed, or the tendon, in some instances where tendons are damaged and they don't attach normally to the bone to drive the joint, those muscles can't be used adequately to balance our body's weight over the weakened limb. When the limb is in stance phase. And so in order to counterbalance that, you'll see in the illustrations to come in a second, our body leans over the injured limb to try and reposition our center of gravity and maintain our balance. The last example was in the limb that has altered leg lengths or altered joint angles. And this is actually pretty uncommon, to be honest, because we're talking about significant deformities. We're talking about a limb that's 4 or 5 centimeters shorter than the opposite side. That's pretty rare. But if you see it, you'll know it when you see it, as they say. And in those instances, you'll see the client or the patient having a vertical dip. So when they walk, their trunk bobs up and down when they put weight on the shorter limb. So in this example here, in these two cartoons you see on the left, at the top and the bottom, we've got some abnormal gaits. And in particular, we're talking here about the lateral lurch or what's called a Trendelenburg gait. So this is the type of limp we most commonly see in patients or clients who have abnormalities of muscle or tendon. And these are the clients who you'll see lurching as they walk. So what's happening in those clients, in particular, if you look at the cartoon on the top left-hand side, in the normal situation, when you've got your body weight balanced over, in this case, the right foot, the gluteal muscles that you see illustrated there, attaching onto the pelvis and the hip joint, they're basically contracting and holding the pelvis level or slightly elevated so that our body weight is positioned in the center. And by those muscles acting effectively, what they're doing is keeping us balanced. Now, when those muscles don't work effectively and they're abnormal, either from tendon damage or nerve damage or muscle damage, then what happens is our body's weight tends to fall away from the limb that's taking the balance. And you can see that on the illustration of the cartoon. In this instance, the pelvis is falling away from the damaged muscles. Now, in order to keep our body upright, we have to bring our center of gravity back over the top of that injured muscle or injured limb. So if you look at the cartoon on the bottom of the screen, you'll see that the center of gravity, CG, has been moved from the middle of the trunk and is now, with a sway or a swing of the trunk, has been positioned over the injured hip joint. This leads to a lurch or a Trendelenburg gait. And as mentioned, this is a fairly inefficient way of moving along. Here's an example. Thank you, YouTube. Here's an example of someone demonstrating firstly a normal gait. So you'll see that when this model has body weight balanced over the weight-bearing limb in stance phase, the pelvis is relatively level. You can see that by his underwear basically staying in a level position, and his trunk is balanced in the middle of his body. It's not leaning off to one side or listing. His arms are near his sides. They're not sort of swung out miles out to one side. And that's relevant because you'll see in the next example when we have someone with an injured set of gluteal muscles. Now, this lady has an injured left hip joint. Her gluteal muscles on the left-hand side don't work. When she puts body weight on the left foot, you'll see her trunk swings over the top of that left hip, to keep her center of gravity or her center of mass over the left hip. When she gets back onto putting weight onto her right foot, you'll see that her body weight is fairly symmetrically balanced now, relatively speaking, at least anyway. You'll also notice that when she puts the weight onto the left leg, the left arm swings out to the side, again, to further increase the amount of mass over the top of that left hip joint. So, now that you've seen it, you know what it looks like. You'll go out in the street now and you'll probably go, that person has a Trendelenburg gait. Here's the same thing seen from a sort of a side profile. Again, you'll notice that when the left foot hits the ground, there, the body swings over the top of it. The right foot, she can maintain balance fairly well. This last example is a much more exaggerated example. This patient has a problem with her right hip, though, in contradistinction. So you'll see that when the right hip foot's the floor, the trunk swings to the right and the arm comes out to the right-hand side. The right arm comes out. The left arm doesn't do as much. So that's an abnormal or Trendelenburg gait due to muscle inequality. Okay. So what does this mean as a consequence? Well, if we're having pain when we're walking, the other way we can manage it, apart from using limping, is to reduce the speed with which we walk. Because the forces that act across a joint are basically in proportion to the patient's body weight and height, neither of which they can really alter or control in the short term. Or the other thing that they can control, on the other hand, is how quickly they walk. Our walking speed is determined by how long a stride we take and how many of those strides we take per second. So if we take fewer strides or shorter strides, we can reduce our walking speed and therefore reduce the forces acting across a painful joint. That's an alternative way of managing the problem as far as the patient is concerned. So when it comes to this, when we look at the biomechanics of an abnormal gait, when we've done what are called joint force studies, we can actually see that when a patient has an injured joint, they can, physically speaking, essentially reduce the amount of force acting on that injured limb to the point where there's virtually no more than just your body weight on that injured leg at various points during gait. So they will either alter their lurching or they'll alter their gait speed to reduce the amount of force on the joint to a point where it's effectively tolerable. What's interesting is that the normal or uninjured joint in those circumstances has been shown to see no increase in force when there is an injured limb on the opposite side compared to those seen in normal gait. So the normal limb in a situation where a patient has one side that's injured, the opposite side doesn't necessarily experience any significant increase in force across that joint, certainly not in the short term, at least anyway. So when we look at the normal limb in these circumstances, not the injured one, but the normal limb, when we have a Trendelenburg or that lateral lurching gait, in those circumstances, when the normal limb gets the heel to the floor and enters into stance phase, we do see in some instances that the normal hip joint has less coverage of the hip socket. So if you look at the cartoon on the bottom and left of your screen here, when we're looking at this limping cartoon, if the right hip is the injured hip, when that side hits the floor, the hip joint is lurching away from that. Well, it's actually lurching off that side, and the area of the hip joint that's got contact is actually diminished. That diminished contact surface, remembering that pressure is the amount of force and inversely proportional to the surface area that the force is being applied to. If that surface area is diminished, then the pressure across that joint does go up. Similarly, in those circumstances, on the good side, when the good leg hits the ground, the gluteal muscles on that good leg tend to be a little bit more stretched out because the body has been lurching away from that good leg. And so those muscles are actually under greater tension. That slight increase in muscle tension does have to exert more force to correct the position of the pelvis. And in turn, that increased force by the muscles also increases the contact pressure across the joint. Lastly, in those circumstances where we've got a paralyzed limb on one side, it takes a longer time to swing that paralyzed limb through to get to stance phase. What that means is that the good limb has to spend more time in stance phase, whilst the injured limb is spending more time in swing phase. And that longer stance phase means that there is a longer period of time for that good joint to have those higher contact pressures. So when you look at it, in theory, well, maybe having a Trendelenburg gait does increase the pressure across the joint. However, what you're about to see is that that problem has to go on for years to manifest as an arthritis through what was previously a normal hip joint. When we have an antalgic gait or a pain-affected gait, as I mentioned, the stance phase is shortened on that injured gait, on that injured leg. And so we have a quicker swing through of the normal leg to try and offload the injured leg. Now, that quicker swing through would theoretically lead to a more rapid acceleration of that uninjured leg to hit the ground. And that could, in theory, increase contact pressures when that uninjured limb hits the ground, because again, force equals mass times acceleration. The uninjured leg is being accelerated quicker to try and get it to the ground faster to offload the injured leg more quickly. Again, not something that we see causing arthritis in the short term. The last instance is that short-legged gait. So if you look at the cartoon towards the bottom on the center of the screen, you'll see that there's an example of someone with a normally positioned pelvis with normal thigh bones. And then the cartoon slightly towards the right-hand side of that shows that the thigh bone on one side is shorter than the other, leading to a list towards that short side. So in those instances, we see that the gait pattern is very similar to a Trendelenburg and has the same sort of mechanics as a Trendelenburg with a lateral, but without the lateral trunk lurching. But what we see is, again, a difference in the contact areas and the amount of pressure going across the joint in those normal or longer limbs compared to the shorter or abnormal limb. This in turn, again, leads to greater tension in the muscles and, in theory, again, higher contact pressure and wearing out of the joint, but again, over years, not over a few weeks or a few months. So when we look for evidence of this, do we actually see it? So there were studies in the 1960s on patients who still had what was called post-polio syndrome. So these people had had the polio infection, it had damaged their nerve endings, and they had to walk with a limp. And generally, when they walked with a limp, it was the Trendelenburg type, paralytic type, where they would throw their trunk over the injured side. And what we found in those patients is that the normal side almost never developed symptomatic arthritis in the good leg. Now, it's possible that occurred because those patients were much lower demand. Because they had polio, they didn't try to run or jump, but maybe the level of demand was too low for them to become symptomatic. Absolutely possible. When I started doing medico-legals, I actually had a meeting with a retired judge, and we were talking about this sort of situation of causality or consequential injury. And he brought up a fascinating study that I was subsequently able to find. And he said that there was a study done in the 1970s where they looked at amputees because, frankly, let's face it, the worst thing that can happen to a leg is to lose part of it. To have an above-knee amputation is a pretty significant injury, and it should, in theory, cause a lot of differences in the way you walk and strain on the uninjured leg. And this retired judge pointed out an article to me and said he couldn't remember the name of it exactly or the reference exactly, but he said that when he did his research, he found that particular journal article said that although there was a marginal increase in arthritis on the normal side, it wasn't usually of great consequence. So his feeling was that this is probably not a real thing. That being said, I've gone and done a little bit more digging. And so what have we found? So there's a couple of studies based in the 1970s looking at World War II amputees. So these are people who had amputations in the 1940s and had prostheses that were much less advanced than what we have now, that were built sometime in the 1940s and went through to the 1970s. So we're talking about a 30-year experience of walking with an amputation. And what these studies showed is that there actually was a slight increase, well, there was an increase in the incidence of arthritis in the non-amputated limb, but it took 30 to 50 years for that arthritis to manifest. So it didn't happen within a few weeks or a few months or even 1 or 2 years. It happened over decades. The feeling being from those articles that it was related more to the fact that they had gait asymmetry and also that those amputees were probably more sedentary. And so with the sedentary lifestyle, they increased their body mass and that in turn increased the load on the uninjured joints. There have been further studies done in the 1990s which have shown very similar findings. So to summarize, does limping, well, actually, I shouldn't summarize, this isn't quite the summary yet. So when we look at it, does limping on the injured side increase the pressure on the normal leg? So what we can see here is, certainly in the short to medium term, weeks, months, maybe even a year or two, the answer is probably not to a significant extent. However, if they do have a substantially altered gait pattern with that Trendelenburg lurch, or a severe leg length discrepancy or significant deformity in the leg such that they've got a significant shortening, and that their limping is taking place over a long period of time, then yes, maybe it does start to increase the pressure on the normal leg. But over a few months or weeks, certainly not. So sometimes we have, in my case, patients, or in your case, clients saying, well, they had to use crutches or a cane or a plaster cast or a cam boot. By the way, cam is not actually talking about a rocker bottom, although that's what they have. Cam actually stands for controlled ankle motion. So cam boots are designed to stop the ankle joint from moving backwards and forwards. And in order to compensate for it, they have a cam or a bend underneath them, but the actual CAM for cam means controlled ankle motion. So in using these things, what do we find? Does that increase the pressure or the force on the normal limb? The answer is no, it doesn't. Not to any great extent. When we use crutches or a cane, it actually takes the pressure off the injured leg extremely well. At worst, it may increase the pressure on the uninjured limb by, say, up to 1 kilogram at most. So we're not talking a significant increase in weight over the uninjured limb when we're using crutches or a cane. And we find that usually most patients, once they get used to using the crutches, they don't have a significant change in their rhythm of gait. So the gait still works fairly fluidly or fairly naturally. So in summary, using the use of crutches or a cane doesn't likely cause injury to other parts of the lower limb anatomy, at least anyway. Hands, wrists, shoulders, that's another story. I won't get into that today. Having to use a plaster cast or use a cam boot, look, these things weigh maybe a couple of kilos at most. So similar to the crutches, they don't actually add a huge amount of weight to the, certainly not to the injured limb because you're usually going to offload it, but even to the uninjured limb, they don't add a huge amount of weight. So in that regard, they're not going to increase the likelihood of developing arthritis in the opposite limb. Using a cam boot can actually cause some discomfort, usually more so from muscle spasm and fatigue, because they do have a fairly thick sole on them, a 2 or 3 centimeters thick, on a cam boot sole. And so what a lot of clinicians will do is ask the patient to wear either a thicker soled shoe on the uninjured side, or you can get these things called an even up, which you can see the illustration for down there on the bottom, which is basically a strap-on sort of platform shoe, or a platform that you can strap onto your normal shoes that balances you out and takes the pressure off the other hip and the low back. So canes, crutches, cam boots, and casts don't tend to increase the likelihood of developing an injury to the opposite side to any great extent. And that brings me to the sort of the end of the formal part of the talk. So to summarize, from an orthopedic surgeon's point of view, it's great to have all the notes, the AMBO's notes, the treating practitioner, the treating doctor's notes, the surgical notes, the operative notes are really important to have, and to have access to actually be able to see the images that your clients have actually had done by hook or by crook. It actually does make a big difference. And hopefully, whichever IME you're using, they take the time to actually review the imaging and not just the radiologist's reports. And in answer to the question, does injuring one lower limb cause a later injury to the opposite lower limb? As I've banged on, I guess, the answer in general is not in the short term, that's for sure. And if it's going to do so, it's going to take many years or decades, and it's going to need a significant, persistent gait abnormality on the injured side, like a significant lurch or a substantial difference in leg lengths to really cause injury to the opposite lower limb. And I think that brings me to the end of my bit.
Thank you, Dr. Robin. Yeah, thank you, Dr. Robin, for a very thorough presentation. I do got a question from a case manager who could not attend,
Sure.
but it's just basically with that, when you say with all these records that you're requiring with the images, like how long or how far should it go back to? for these types of cases?
That's a very good question. I'm just going to try and figure out how to unshare my window. Hang on a second. Um, how do I unshare? Um,
Oh, it's already unshared.
oh, okay. Sorry. So you can see me now. Oh, good.
Yeah, yeah,
Okay.
yeah.
Thanks for that. So sorry. The question was, how far back should the imaging go?
Yeah, or how far back should all these records go? Um,
Okay. Records. Well, look. Okay. So when it comes to things like the treating doctor's records, if it's another specialist, like another orthopedic surgeon, as far back as you can get, ideally, if it's pertinent and related to the injury at hand. Now, if they've got a knee injury, I'm not going to be that interested in their shoulder injury or their neck injury. That's clearly not relevant. So it needs to be, you need to use a little bit of, shall we say, common sense in that regard. But the first time that particular part of the anatomy has been injured, whether it was 5 years ago and then settled down and then has had a recurrence 5 years on, well, that information from 5 years ago may well be very, very relevant. And so it's worthwhile getting that sort of information if it's pertinent to the joint. If they've had a previous, for argument's sake, if they've had a previous arthroscopy of that knee, then I'd love to know what happened at that arthroscopy, how they recovered from that sort of procedure, and what their imaging was like at the time of the arthroscopy. And then looking 5 years further on down the track, when they now come to the attention of yourselves and myself as an IME, that could have significant implications and bearing for a pre-existing condition and therefore potentially apportionment, which I haven't really spoken about to any great extent at this stage, at least anyway. But that sort of information is really handy, and having access to that imaging is really useful. Does that
yep.
answer the question?
Yeah. Yeah. Thank you so much, Dr. Robin. There's another question from one of the attendees, from
Sure.
Helen. Helen asked, can you explain the difference between an MRI and an MRA and whether one is more useful than the other to understand the relevant pathology?
That's an excellent question. So MRI and MRA stand for magnetic resonance imaging and magnetic resonance angiography. Angiography means taking a picture of what the blood vessels are doing specifically. So they're particularly looking at blood vessels and blood flow within that area that they're screening. Um, MRI is designed specifically, in orthopedic terms at least anyway, to look in detail at what we call soft tissues. So not so much the bones of the limbs, but the muscles, the cartilage, the ligaments and tendons. And to look for any sort of fluid collections around those areas. And that's what it's designed to look for. And when we see and when and where we see fluid, we're looking at areas where there's injury or damage usually, or pathology. You can also use MRI to look at bone, obviously, and it's designed to look at bone so far as bone bruising or bone edema, where we've got more fluid in the bone than would normally be there. And again, like it is in the soft tissues, if there's excess fluid in the bone, it's usually a sign of injury, be it a fracture or a trauma or an infection or even a tumor, cancer. And all these things can cause fluid to accumulate within bone or to build up within bone, showing signs of damage or pathology.
Yep.
Any other
Thank you, Dr. Robin. Yep. So Helen sent a heart there, so probably
Thanks,
answered your
Alan.
question. But yeah, I don't see any other questions in the chat box. So thank you so much for a very thorough presentation.
Pleasure.
We got yeah, people saying it's a fantastic presentation. Thank you for the presentation. I can tell you put a lot of effort in it, and the slides very useful. So I'll
Yeah,
send out the slides to the attendees in
sure.
PDF format. But yeah, thank you so much for joining and hosting the seminar with Mac.
Thank you very much. Thank you to all who attended, and I hope I didn't bore you to death with physics and biomechanics. Um, but if you're going to understand why injuring one limb doesn't cause problems with the other, you need to understand the basis behind it, and it's not just because there's actually some science and biomechanics behind it that make good sense. I'm happy to take any questions that you guys may have later on. If you do want to get in touch, you'll have to do it through the appropriate channels. But
Yeah.
happy to take any questions or questions later on down the track.